I get going. We're good. Um, Christina, thanks for coming and joining us for Grand Rounds. And we've got your title here. Interesting, the association between newborn feeding methods and adverse outcomes in the first month of life among women with in utero SSRI exposure. So first, I just want to acknowledge that we're built on the unceded Algonquin and Anishinaabe territory, and that the peoples of the Algonquin and Anishinaabe Nation have lived on this territory for millennia, and we honor them in this land. And with keeping that in mind, even virtually, we're in that space. So, yeah. So Christina is a nursing research scientist at the CHEO, focused on the mental health, addictions, and substance use health of childbearing families and their newborns. She completed her PhD in nursing program at Queen's in April 2025 and is a co-author for the SOGC Perinatal Mental Health Guideline, providing nursing expertise as a representative on the CAPWHN, so the Canadian Association of Perinatal and Women's Health Nurses. For the last 12 years, she worked as a perinatal consultant for the Champlain Maternal Newborn Regional Program. And during this time, she developed a perinatal mental health and substance use portfolio to improve the delivery of person-centered, evidence-based care for this population of childbearing families. So Christina, again, thank you. We're up to a good number of participants as well. Usually I have to wait a little bit to get up there, but we're ready to go.
Perfect. Thank you so much. I'm so happy to be presenting this morning and sharing my dissertation research. So we'll jump right in. And I always want to start with a story when I do presentations. So I want you to imagine for a moment that you or your partner are pregnant and have a history of depression. And after a discussion with your healthcare provider, you've continued to take your antidepressant medication throughout your pregnancy. Now imagine that you've recently given birth to a beautiful baby. You're memorizing all the sweet features of the baby's face. You're staring at the hands and the toes and spending so much time learning to care for your baby. And now imagine that your baby is having withdrawal signs due to the antidepressant medication that you were taking, and you didn't even know that that was a possibility. So a few years ago, when I was working as a perinatal consultant for the Champlain Maternal Newborn Regional Program, or CMNRP, I received a consultation request from a nurse educator about the care of babies who were exposed to antidepressant medication. And this led to the focus of my dissertation research, which we're going to talk about today. So in terms of objectives, we're going to talk about the neonatal withdrawal signs following a selective serotonin reuptake inhibitor medication, or SSRI. And we're talk about the association between feeding method and adverse outcomes. And we'll talk about some research directions. There's a lot of research gaps here and a lot more work to be done. And then I'll finish with talking about some available resources that might be of interest for you in your practice and also for our families who are having children right now. And so, as spring is in full bloom, I want to acknowledge the lands on which I work and live. And so, in Ottawa, this is the unceded, unsurrendered territory of the Anishinaabe Algonquin Nation. And the photo on the left is the apple tree in my backyard. And if you look real close, that's me doing some gardening, which is my favorite pastime. And on the right, in Kingston, Queen's University is situated on the traditional Anishinaabe and Haudenosaunee territory. And so I actually grew up in Kingston, and this is the property, my family property, where my older brother actually now lives. And so I'm grateful to live and learn and play on both of these lands. And I want to acknowledge my supervisors and my whole committee for the support in guiding me in this research. And I also want to acknowledge the funding that I received. So the CIHR Doctoral Research Award, the Canada Graduate Scholarship. So that was an enormous support to be able to do the research, especially the retrospective cohort study that I'll tell you about. And I was also so privileged to be a trainee in the Canadian Mother-Child Collaborative Training Program, or CAMCO. And I can talk a little bit about that, but it was just phenomenal training support about pharmacoepidemiology. So, to jump right in, the rates of perinatal anxiety and depression have increased from 20 to 30% in the last 5 years. And it's really important to have adequate treatment of depression in pregnancy. It's important for maternal, fetal, and newborn health. And the selective serotonin reuptake inhibitors are the first line pharmacotherapy for moderate to severe mental health concerns. And this has been recently confirmed by two national Canadian guidelines, and I'm going to share links to those at the end of the presentation. In terms of the consequences of untreated depression, pregnant women who are depressed compared to women without depression have a higher risk of labor induction, cesarean delivery, ICU admission, extended length of stay, and severe maternal morbidity. There's fetal effects as well, included hyperactivity and irregular fetal heart rate. And in terms of the newborn effects, you can see that there's increased cortisol and norepinephrine levels, decreased dopamine levels, altered EEG patterns, reduced vagal tone, stress, depressive like behaviors. And then there's other outcomes like increased risk of preterm birth less than 37 weeks, severe neonatal morbidity, mortality, and NICU admission. On the left, I've listed the risk of antidepressant medication exposure, and you can see that they share some of the same risks. And so it's really important that healthcare providers help individuals with moderate to severe depression to actually weigh the risks and the benefits of treated and untreated depression. So the risk of untreated depression that I just talked about, and then the benefits of medication for both themselves as well as the growing baby and the newborn. I listed on this slide here the names of the SSRI medications, just in case you weren't familiar. So there's six that are listed here that fall into this category. And you can see that the half-life for most of them is about a day, 24 hours. The exception being fluoxetine, which is 4 to 6 days. And that's important when we talk later on in the presentation. It's estimated that up to 30% of newborns with a history of in utero SSRI exposure will experience withdrawal. And Chambers and colleagues were the first ones to report these signs in 1996 following exposure to fluoxetine. And they are the ones that introduced the term poor neonatal adaptation. However, neonatal withdrawal is the most common terminology used by researchers and clinicians. And you can see in the boxes below, these are some common signs of withdrawal. I created the term NeoWISE to refer to neonates with in utero SSRI exposure. And there are many gaps in the literature related to the NeoWISE. So few researchers have included newborn feeding method in their study designs and analysis. And the evidence comes from small observational studies and case reports. Currently, there's no validated instrument for assessing newborn withdrawal signs in the NeoWISE. And then you see inconsistent approaches to monitoring the health status of the NeoWISE. There's also a lack of a standardized definition for withdrawal. And so there's a debate in the literature. Is this a withdrawal syndrome? Is this toxicity due to serotonin excess? Or is this a behavioral syndrome? We actually still don't know. And then data regarding healthcare utilization is a notable gap. And so most researchers have focused on NICU admission. And finally, there's a lack of evidence regarding non-pharmacological interventions. And this sharply contrasts with the extensive evidence base that we have related to newborns with in utero opioid exposure. So to address these knowledge gaps, I conducted a multiple methods research study for my PhD to explore and develop evidence regarding the impact of in utero SSRI exposure among newborns who were breastfed in the first month of life. The scoping review study, I explored the existing literature, and then the retrospective cohort study, I developed new knowledge. And the conceptual framework that I used to guide my dissertation research was the interaction model of client health behavior by Cox. And the elements and the variables in this model were relevant to my research questions, and I actually found it very useful. So for my scoping review study, the review question was the following. What is the extent and type of evidence in relation to the characteristics of breastfeeding newborns in the first month of life who've been exposed to in utero SSRI medication? And the population I was exploring was newborns, 31 days of age or less, who were exposed to in utero SSRIs. The concept was the impact of newborn withdrawal signs or outcomes following in utero SSRI exposure in any trimester of pregnancy. And the context was any aspect of breastfeeding or breast milk feeding, regardless of method or route. So I followed the 9 steps in the JBI methodology for scoping reviews, and I published the study protocol and JBI evidence synthesis. So in brief, I searched 7 databases, and the search terms that I used were broad to reflect this variety of terms related to withdrawal from SSRIs, as well as a variety of terms related to breastfeeding. And so the types of sources were peer-reviewed primary quantitative or qualitative studies or mixed methods. And I used Covidence systematic review software to conduct all the steps. And importantly, there were 2 independent reviewers who conducted each step of the scoping review process. To organize the extracted evidence, I used the elements and variables in the interaction model of client health behavior. And I put a red box around the variables that I anticipated that I would find in the included sources. So over 2,000 studies were imported for screening with an additional 40 identified from citation searching. So that made up 2,200 potential sources. 1,714 studies underwent title and abstract screening with 193 full text studies reviewed. And then there were 28 studies that were included. And importantly, this reflected a combined total of 393 babies. The publication years ranged from 1995 to 2023, with the majority in the late 90s and the early 2000s. The United States had the most publications, and there were 4 sources from Canada. Fluoxetine was the most studied or most reported. And this makes sense because fluoxetine was the first reported SSRI medication that was developed in 1974. And so most sources reported a single SSRI medication. However, cohort studies investigated and included multiple SSRIs. Case report was the most utilized methodology, and you could see that 16 out of the 28 studies were case reports. In terms of results, the context of breastfeeding was not detailed in almost half of the studies. There really was a lack of breastfeeding definition. And in fact, only 2 authors actually provided a definition of breastfeeding. The data were primarily collected during hospitalization after birth. And the newborns that were reported were primarily full term, so that's greater than or equal to 37 weeks. Most were born by vaginal birth, if it was reported at all, and surprisingly, 2/3 didn't actually report, like specifically say how the baby was born, which is surprising because mode of birth is really important when you think about adaptation and outcomes. Reassuringly, few newborns had low APGAR scores of less than 7. And it was also reassuring that there were few adverse health outcomes. And in regards to feeding, most of the babies were able to continue to feed, and there was no change in the newborn feeding method. In terms of the question related to utilization of healthcare services, you can see that postnatal length of stay and admission to the NICU or special care nursery were reported in 9 out of the 28 studies. And when there was admission to the NICU, the respiratory distress was the most common reason. There were a few reports of emergency department visits, only 2, and there were 4 reports of readmission to hospital. And so from this study, we can see that most of this evidence is coming from case reports. It's focused on term newborns. It's rare for severe morbidity. which is all reassuring findings. There were many limitations, though, that I noted. So, wide variations in the methods and methodologies that researchers have used to investigate this population. There's not been a validated tool to assess the newborns. Most had used the Finnegan scoring tool as an assessment approach, and this was not an assessment tool that was designed for in utero SSRI exposure. It was developed to assess for in utero SSRI exposure, but they share similar signs, so that this is understandable why clinicians and researchers are using this. But we don't yet have a validated a tool, and we need to do that. And we see that there's inconsistencies in even reporting the SSRI medication exposure. So any dosing changes, it just was very poorly reported. And the breastfeeding, there was really not a lot of details about how much breastfeeding, how often, how long, so there's a lot of opportunity to improve reporting related to how the baby feeds. So some of the strengths for the scoping review study was following JBI methodology. And so this is a robust methodology with a lot of guidance and resource, and to have the published protocol, which keeps you within the restraints of what you set out to do. I did work with a health science librarian at Queen's University, and the search strategy was pressed. So that's the peer review of the electronic search strategy. And that was really helpful to improve the search. I talk about this as finding a needle in the haystack, was really this scoping review study related to this particular question. Both reviewers, we had neonatal expertise, which was really helpful when we were looking at the sources and trying to find the details related to our search question. And another strength was that we looked at only one antidepressant medication category. I think initially, early in my program, I was thinking, I want to investigate all of it, boil the ocean. But it was really important advice that someone had provided to just focus on one category. And I think that was very wise advice. And I'm really glad that I selected only one category. In terms of limitations, I didn't search the gray literature, and I didn't anticipate that anything new would surface that would change the findings. So based on that, scan of the literature and understanding of what was out there, I wanted to improve the database and the information that we actually had related to this population. And so I planned a retrospective cohort study of Ontario newborns. And I had two research questions. In neonates exposed to SSRIs in utero, what is the association between feeding method and adverse neonatal outcomes during the hospitalization stay after birth? And the other question was, in breastfed neonates as compared to formula-fed neonates, what is the healthcare utilization within the first 30 days of life among neonates exposed to SSRIs in utero? So the cohort study included all newborns born in Ontario hospitals between April 1st, 2012 and March 31st, 2020 to pregnant women who were beneficiaries of the Ontario Drug Benefit Program and were dispensed an SSRI medication. And so again, just as a reminder, I listed the 6 medications on the left. The study exposure was feeding method, and this was defined as the type of oral feeding given to the newborn from the time of birth to discharge from hospital. So this is the BORN definition, Better Outcome Registry Network. Exclusively breastfed was defined as receiving only breast milk from birth until hospital discharge. And newborns with unknown feeding and no feeding were excluded. So there were 1.12 million births during the study timeframe, and of those, 9,926 were SSRI exposed. And so the final new NeoWISE cohort included 3,321 newborns who were exclusively breastfed and 1,758 who were formula fed only. So data were obtained from multiple databases and registries within ICES. And so the data were linked using a matching number that's validated at ICES. So you can see that there's provincial databases as well as national databases. The primary outcome was neonatal withdrawal from maternal use of drugs of addiction, or P96.1 ICD-10 CA code. And the secondary outcomes were rate of transfer to the NICU or special care nursery, a prolonged postnatal hospital stay, which was defined as greater than or equal to 3 days, visits to the emergency department, and readmission to hospital. And I hypothesized that breastfeeding would be associated with a lower risk for all outcomes due to the benefit of SSRI medication transfer through breast milk, due to large intercellular gaps between the alveolar cells in the first couple days of life. And I'll show you a picture in a second. And then also the benefit of close skin to skin contact that happens during breastfeeding. So that was my hypothesis. And I found this diagram in the last couple of years, and I found it really helpful to just show the potential mechanism of what I was talking about here related to my hypothesis. So on the top that you can see the alveolar cells have gaps, and the medication can transfer easily between these gaps to the newborn. After the first few days of life, those intracellular gaps close, and then the medication has to transfer through the alveolar cells. So, this is really the mechanistic action related to what I was investigating and why I had the hypothesis that I did. In terms of analysis, the differences in maternal and newborn characteristics by feeding method were compared using standardized differences, where greater than 10% indicated an imbalance between these exposure groups. And to address the imbalance between groups and to ensure that they were similar, the mother baby pairs based on feeding method, I used inverse probability of treatment weights to do this. The covariates in the box on the right were the independent variables in the propensity score models. I then estimated the risk ratios between newborn feeding method and newborn withdrawal that was adjusted for confounding. And then the secondary outcomes were modeled using the same approach. And I conducted sensitivity analysis by including only newborns with third trimester exposure, because some authors had reported an association between third trimester exposure and withdrawal signs. And the other sensitivity analysis that I conducted was defining breastfeeding as any breastfeeding as the exposure rather than exclusive breastfeeding, just to see if there's any benefit of any breast milk. So on this slide, it's selected baseline characteristics. I don't have enough room to show you everything, but these were the variables that were different between the formula feeding and breastfeeding groups. So you can see the red box indicates a standardized difference of greater than 10%. And then after the propensity weighting, you can see that all of those are less than the 10%. So that indicates that the groups were balanced after the propensity score weighting. So I just wanted to show that to you. In terms of results, the exclusively breastfed newborns as compared to formula-fed newborns had no difference in risk of neonatal withdrawal. So the outcomes on this table are listed on the left, and you can see the feeding method kind of in the middle and the proportions, and then the risks on the right. So no difference based on feeding method for withdrawal. We did see that there was a lower risk of transfer to the NICU among the breastfed newborns compared to the formula-fed newborns, and that held in the adjusted model as well. When we did the sensitivity analysis looking at the third trimester SSRI exposure, the risk of withdrawal was similar to our primary result. And in terms of transfer to the NICU, it was no longer statistically significant when we adjusted for the confounders. And so that likely is related to the small sample size and lower power. When we looked at any breastfeeding versus formula feeding, there was no significant difference in risk of neonatal withdrawal or no risk of transfer to the NICU. And now we're getting into the health care utilization data. So on the left, you can see length of postnatal stay, prolonged, visit to emergency department, and readmission to hospital. So these results show us that breastfeeding newborns had a lower risk of prolonged postnatal hospital stay. However, they had a greater risk of emergency department visits and readmission to hospital. Again, the sensitivity analysis looking at third trimester exposure, we observed a similar trend. However, there was no longer an increased risk of visits to the emergency department for the exclusively breastfed newborns, but they continued to have an increased risk of readmission to the hospital. When investigating any breastfeeding versus formula, the only statistically significant finding was the increased risk of readmission to hospital for the breastfeeding newborns as compared to the formula-fed newborns. So I'm just going to summarize all that. That was a lot of data for folks. So to summarize, overall, there was a low risk of neonatal withdrawal and no difference in risk among exclusively breastfed and formula-fed newborns. So that did not support my hypothesis. In terms of the secondary outcome, there was a 20% lower risk of NICU transfer in exclusively breastfed newborns. And this finding did not endure in the sensitivity analysis when looking at the third trimester or any breastfeeding exposure. And there was a 16% lower risk of prolonged postnatal stay in exclusively breastfed newborns. And this finding did not endure in sensitivity analysis when looking at outcomes for the NeoWISE with any breastfeeding exposure. So two hypotheses are supported there. And then for healthcare utilization, exclusively breastfed newborns had a 42% higher risk of visits to emerge and a 78% higher risk of readmission to the hospital. So altogether, these findings of my research only supported two of my hypotheses, that they exclusively breastfed newborns had a lower risk of transfer to the NICU and a lower risk of prolonged postnatal hospital stay. However, contrary to my hypothesis, I found that exclusively breastfed newborns had a higher risk of emergency department visits and higher risk of readmission. So the strengths of the retrospective cohort study is that all newborns had in utero SSRI exposure. And so I reduced bias due to confounding by indication by only selecting pregnant women who were dispensed an SSRI medication. I was able to use linked databases and a validated birth registry, and this allowed me to investigate the impact of feeding method as well as healthcare utilization. And by using dispensing data from the Ontario Drug Benefit Program, I was able to identify the timing of exposure, and this enabled me to explore the association with the third trimester in utero SSRI exposure. And the use of inverse probability of treatment weights of propensity scores to balance the differences in baseline characteristics helped me to minimize confounding bias, which is really important in observational research. In terms of limitations, there's a lack of generalizability of these findings because the cohort was restricted to women who were recipients of the Ontario Drug Benefit Program. And this only represented 1% of the population of individuals who gave birth in Ontario during the study timeframe. It's not possible to know for certain if the mothers took the medication as prescribed. So therefore, there might have been misclassification of medication exposure when identifying the cohort for this study. Another limitation was that data were limited to the variables that were available in the ICS data holdings. And so the specific withdrawal signs of the newborns in our study are unknown because I used a diagnostic code as the primary outcome. And so as a result, I have likely underestimated the incidence of withdrawal. And as I mentioned before, the diagnostic code is not specific to SSRI exposure, and so it might not be used by all clinicians. As at the current time, there's no other variable that exists in health administrative databases for SSRI exposure. And the final limitation is that newborn feeding data were only available until hospital discharge. So that's really important to keep in mind as we were exploring the health care utilization data questions. So to sum up for the cohort study, that we see that the risk for newborn withdrawal was low in the NeoWISE cohort, and other reporters authors reported up to 30%. And I did find studies that it was even like 60% that they were reporting. And those differences were related to the assessment approach used, and the thresholds to identify withdrawal in my study would have been quite high to actually get a diagnostic code. And so that explains the difference between my results and what's reported by other authors. Consistent with other authors, we see that the healthcare utilization following postnatal hospital discharge was infrequent. And so that's a reassuring finding, and it's consistent with what I found in the scoping review study. So we need to do more research. I would suggest a prospective cohort study would be great to facilitate improved data collection on important variables. So we just need more data about mental health status of the individuals, their medication history, more details about the newborn feeding, and the newborn withdrawal signs that both parents and healthcare providers are observing. And so by having more rigorous data collection in these areas would really improve the surveillance and reporting of adverse outcomes. And that will allow us to obtain a more precise estimate of the prevalence of withdrawal in the NeoWISE. And so to do that, we actually urgently need to gain consensus on a newborn assessment approach and to ensure that this is consistently used by clinicians and researchers. I would suggest developing a core outcome set of variables reflecting the most common signs of SSRI withdrawal. And I think this is a really important area for knowledge development. And finally, qualitative studies. I was very, very surprised that that did not come up in the scoping review studies at all, to not find any qualitative studies on the parent experience of caring for a baby or even healthcare providers caring for this population. So it'd be really important to capture the mother's perception of the newborn behavior, their education needs, as well as the healthcare access following discharge from hospital, especially right now when things are very challenging in terms of finding primary care. And so when you go back to my conceptual model and the framework that was using, it would be really exploring those questions in the center of the model, which I didn't investigate as part of my two research questions. So, in conclusion for my dissertation, and then I'll move on to some of the resources, I conducted a multiple method studies. This was a scoping review study and a retrospective cohort study. And, we had 393 babies for the scoping review study. And then I added 3,321 breastfeeding newborns with the retrospective cohort study. And so from these studies, we gain a better understanding of the impact of in-utero SSRI exposure on newborns who are breastfed. And I believe that healthcare providers can use this knowledge when providing patient education. Pregnant women are often concerned about taking medication during pregnancy, and nurses and other healthcare providers can use these findings when counseling expectant parents. And it's important to provide anticipatory guidance to families about potential signs of withdrawal and when to seek healthcare after birth. It's really important. And another important message is that, serious adverse events are rare, which is very reassuring. But it's really important for parents to be aware of when to seek health care and to make sure that they do get health care in a timely manner if there are concerns. And so I think these studies really contribute to the development of some evidence-based newborn feeding and care recommendations that can really help with shared decision making between healthcare providers and families. I like to tell this story because, again, early in my program, I talked with a neonatologist, and I think it really underpins some of the importance of this research. It's important to accurately and timely diagnose newborns to prevent treatment delays and to limit the number of potentially painful procedures that a newborn might require. I think this could help to reduce healthcare costs and actually prevent unnecessary suffering from the perspective of the babies, but also for the families. It's so stressful. And so, this is a story that I talked to people about that a neonatologist told me from an NICU. And so it was a baby that was readmitted due to seizure activity. And this baby underwent, not this baby, this is another baby, but underwent testing, including a lumbar puncture, magnetic resonance imaging, and electroencephalogram. And at the time, the differential diagnosis was mild hypoxic ischemic encephalopathy due to these observed seizures. However, that was ruled out, and the neonatologist inquired about substance use. And the mother denied using substances, but then she mentioned she'd been taking an antidepressant medication for the last 10 years. And so then with this information, the neonatologist was able to establish a diagnosis of poor neonatal adaptation syndrome and then implement the appropriate interventions. So I think it just really illustrates the importance of, potential adverse outcomes, the monitoring and support that's required. And we kind of have to find this balance between not over medicalizing or over treating. And so, future research, I want to look at the resuscitative needs of newborns because that's still an unanswered questions. Anecdotally, we hear providers saying like, sometimes the babies, they just need a little bit of help after birth. They're a little bit stunned, they have a little bit of trouble breathing, that transition period's a little bit needs to be supported. And Dr. Merchant at Special Care Nursery here in Ottawa at the Civic, he estimates maybe 30% of babies need to be transferred to the special care for like 6 hours observation. So there's something going on there. And I want to, investigate this question with the cohort that I have. So this is kind of like the next step. I also think it's really important that we do interviews with parents, really explore things like how are they making decisions? What supports are needed? What are the barriers? The feeding experience, and then the follow up. What kind of community support is going to be really helpful for them? And then lactation consultants too, they're supporting these families after discharge. And so there's a lot of work that we can do here to really maybe create a toolkit. So I'm having some early conversations with them about, what would be useful for their practice and helpful. And these questions really get at that center aspect of the model. So people ask sometimes about the knowledge translation. So on the left, that's the protocol. I did publish the results of the first few results of the retrospective cohort study. And I've been working with ICES to develop, these are some infographics for healthcare providers, just in terms of having that counseling conversation with families. And so I think a next step would be like a patient-facing resource, much, much more simplified in terms of, what's the actual concern here. The message is that, women should have appropriately controlled mental health um, conditions. It's important. Their well-being is really, really important, and that's actually contributing to the baby's well-being as well. So as promised, I wanted to share with you the links to the guidelines. So this is the new guideline from the Society of Obstetricians and Gynecologists of Canada. It's available in English and French. That came out in October. And then we have the CanMat guidelines. So this just came out in February. CanMat is the Canadian Network for Mood Anxiety Disorder Treatments. What's really nice is they have a beautiful handout for patients and families, which really supports that shared decision making. So you can check out those. And I get a lot of questions about, resources. Providers are busy. There's a lot of things to keep track of. How can you remember these recommendations when you have a family in front of you? So one of my favorite is Hale's Medication and Mother's Milk in terms of providing advice and information during breastfeeding. So that's a wonderful resource. It gets updated every 2 years. And what's new is first exposure. So I think people remember we used to have mother risk, and then that's no longer available in the way that it used to be. And so first exposure is now available. This is supported by the Voya Miller Foundation. And it's really beautiful the way that they are going about developing these resources. They're trauma informed, culturally appropriate resources available in English and French. And then there's also the Healthy Pregnancy Hub, which is a growing resource as well, available in English and French. So I thought people might want to hear about that. And for people on the call, anyone interested, any school, any grad school students, um, there's amazing training programs. So I mentioned went to the CAMCO AL training program, the Canadian Mother-Child Collaborative. This is a CIHR funded program. It was just phenomenal. We have experts across Canada. It's free program for me and really robust training in pharmacoepidemiology. So I loved this training program. Highly recommend it. It's still open right now for anyone who's interested in applying. I just got accepted to the GROW cohort. So this is guiding interdisciplinary research on women and girls' health and well-being. So this research is really focusing on intersectionality and looking at, critical social theories and feminist theories, looking at sex and gender, disability, race, these kind of important aspects of research. So I'm so pleased to receive training in this area in the year coming up. And then there's other programs, maybe you're aware of it already, the Empowering Next Generation Researchers in Perinatal and Child Health, so the Enrich program. And then the Impact program is increasing capacity for maternal and pediatric clinical trials. So all this to say, there's a ton of training opportunities to really support you in conducting like great research. So I'll stop right now because I want to make sure that we have time for questions and discussion for today.
Yeah, thanks, Christina. That's a lot of work and very nicely presented. Thank you. Um, uh, People have questions, please put in the chat or put your hands up. I have a couple. One is, you mentioned the case where the mom had been on long-term SSRI use, and I was wondering, maybe one or two things. One is there any difference between kind of more acute SSRI use around specific times in pregnancy? And maybe even pregnancy-associated mental health issues versus long-term use, and also if you or if any studies have looked at multi-parity versus first child. So, what was there any difference in any of those health administrative data and healthcare utilization in first child versus subsequent kids? I may have missed that. I was trying to keep up with your data.
Yeah, no, thank you for the question. There's a lot of discussion and debate in the literature, and I think everyone's like scared about taking medications during pregnancy. And I think historically we've prioritized fetal and newborn health and well-being over maternal well-being. And the evidence is very, very clear. Actually, when you have untreated mental health impact, there are impacts for the pregnant person, there are impacts on the fetus, there are impacts on the newborn. So we're at a point now where we're like, it's not okay not to treat maternal mental health. We need to prioritize mental well-being of our pregnant individuals. So that's a message that's very, very clear in these two new guidelines. And they reaffirmed. So what's reassuring, they've reaffirmed the relative safety of SSRIs as a first-line pharmacotherapy. So there are other antidepressants like that are, not recommended now over these decades of using this, but SSRIs are recommended now. So I think we can have this message to individuals saying, you should take these medications to manage moderate to severe mental health concerns. A lot of the work that we're doing in the region right now is really working on having that conversation. There's still a lot of stigma about mental health concerns and getting access to treatment. So sometimes providers are afraid to even be having questions about mental health well-being because we don't even know where to send them. So we have these system level issues, but we're at a point where we need it to be treated. You'll hear that individuals will hesitate or take themselves off the medication without even talking to a healthcare provider. And they do that because they're afraid. They think that this is a beneficial program. So again, we need to be proactive here in terms of having conversations with individuals. For the data in terms of my study, I can show you the screen here because I know I went over it pretty quickly that, previous live births. So we did see more of the formula feeding moms having a previous live birth compared to the breastfeeding only babies. So there were some differences between the groups in that regard. But I think what you'll see is, sorry, I've lost my whole screen here. You'll see that like women, they'll struggle with that first pregnancy and then they're like, I'm never doing that again. I want to make sure that I wrap myself up with the right support surrounding me. So there's a little bit of wisdom that comes from having that first baby and sometimes that bumpy postnatal period where then they just realize what's going to be required to be a healthy family. And this is what we're talking about. It's like a family type intervention. So not just mom, not just baby, like what's this going to look like for well-being? I hope that answers the question that you have.
Yeah, thanks. In part, I also had that question about duration and if that was a covariate with any of the outcomes that you were looking at. But that's a kind of data specific question. But I do
Yeah.
see that we have a couple of other questions. So Erica.
Okay, thanks. Can you hear me, Christina?
Yeah, hi.
Hi, congratulations on your thesis dissertation and this nice body of work that you've amassed. It's important. It's, as you've alluded to, a very common cause for NICU visits and formal admissions, if not, the observation period that you alluded to. A comment and a question. I just wanted to, I guess, reiterate the challenges of the diagnosis of this condition when babies come into the NICU, and if they do have more severe presentations like very coarse myoclonic jerks, which can sometimes be interpreted to be seizures or in fact seizures, that it's a diagnosis of exclusion. So you do have to go through some of those more invasive investigations to make sure that you're not missing, because a baby who has withdrawal can also have sepsis or can also have HIE or some of the other conditions. So yeah, it is a challenge for us for sure. And then my question was about the finding that the breastfed babies had an increased rehospitalization rate. And, it's always challenging when you don't know why they were rehospitalized. And maybe I missed this or it wasn't fully discussed, but, I wonder whether, first of all, I always worry that people may, sort of take away a negative impression of breastfeeding because of that. And as you said, SSRIs are safe in pregnancy and safe in breastfeeding, and often breastfeeding weighs out as being best versus a risk or a harm. And I wonder whether there is any literature, whether you looked at, and trying to understand that finding that suggests that breastfeeding babies on balance may need to go to emerge because of just breast milk or breastfeeding jaundice or dehydration, difficulty establishing milk supply, those kinds of things. And could that have been, a driver of that compared to the exposure of the SSRI? Was there any look at the literature just to kind of contrast that?
Yeah, so thank you. So 2 points there. So one is about the diagnosis in hospital, right? So the differential diagnosis that happens with the babies. So for sure, we don't take any risks with babies. We need to start investigating. I think what happens there sometimes it's like, are the healthcare providers teams fully aware of the medication exposure and just kind of keeping that in mind? And I think, that is a common medication, but sometimes it's like, they've been taking it for so long and is that information passed down to the resus teams? But I agree, it's really hard because you can't wait if you're ruling out like infection or other concerns. So I totally appreciate that for sure. For the second question about the health service utilization, I think you're bang on. I think what this data reflects is just breastfeeding babies in general. I don't think that this is about the SSRI exposure because other studies, the reasons why these babies, like the entire cohort, it was things like, jaundice, dehydration. Like these are things that babies, breastfed babies will encounter. So I don't think it's specifically related to the SSRI exposure. And I remember bringing this question to my colleagues with the Canadian Association of Perinatal Women's Health Nurses. And I was like, these are my findings. Like, what do you think? And so we kind of all agreed that it's probably just the baseline risk for the babies. For readmission to hospital, that there was an instance of withdrawal signs. So I think in that situation, that's something to monitor. But we have to be so careful to even be sharing this because the overall risk is quite low for families. So we don't want to scare people, but more that anticipatory guidance, like just be aware, monitor, and then go get help if you have a concern. So I think that's kind of the middle ground, perhaps, without
Yeah.
over medicalizing.
Yeah, and I think it's helpful to, remind people of that in discussions and sort of assessments of the findings that it's hard to tease out causality.
Mm-hmm. Yeah.
Mhm. Thanks.
Yeah. No, thanks, Erica.
Yeah, thanks. And I think Julia had put a question in the chat that I think your answer just covered. But Julia, if you want to add anything, either you can ask or put something else in the chat. Um, we had a comment in the chat from Alfred Sisto, just said, excellent presentation. Will be interesting to include a third group, breast plus supplement from day one compared to formula or strictly breastfed. Do you think that was covered in your any breastfeeding sensitivity analysis, or would that be different?
Yeah, and it's a really great question there because we did initially, I was like, any breast milk. And then we thought, truly to see the benefit is that the exclusive breastfeeding would show us the protective effect. And I think the study is underpowered, even to be investigating, those questions, even though it was like all of the Ontario babies. I want to replicate this study in another province. I was having some early conversations maybe with Nova Scotia to see what we can find for those results. But I think that question of any breast milk feeding is an important question to pull out. So the mixed feeding group was included with the exclusive breastfeeding for the sensitivity analysis. And we're thinking like 2 days, right, in hospital. It's such a short time frame. The colostrum, this is a small volume that's going to the baby. And a lot of researchers have actually avoided this whole time frame. They've avoided the 5 half-lives of the medication because this here is showing you in utero exposure, like what we see in the baby and what's coming out in terms of the signs. That's not medication exposure through the breast milk. What's happening is the medication working out of the baby's body. So there's some researchers like Wiseman who's like specifically starting the study recruitment after the medication has kind of had that washout period. So I thought that this was an important question in terms of like intentionally focusing on those early days of feeding. But absolutely, the question is there a difference between the babies who are actually able to exclusively breastfeed compared to the ones who needed to have mixed feeding or formula feeding? And we don't know that answer based on this retrospective cohort study. There could be a fundamental difference between their abilities.
Yeah, thanks.
And their wellness.
Scott.
Hi, thanks. I kind of have two questions, I guess. The first being sort of if there was any measures of the efficacy of the SSRIs during and after pregnancy, like because there's so many like physiological changes occurring at that time, does that affect the way that the medication is affecting them and they're helping their mood?
Thank you so much, Scott, for that question. And it kind of gets back to an earlier question. I think the data that's available is really showing us subtherapeutic dosing because what I'm seeing is that I'm not seeing doses increasing as the pregnancy progresses when the fluid volume has increased, right? We should be seeing some dosing adjustments as the pregnancy progresses. In fact, what we're seeing is that people start going off the medication. Even in my cohort study, by third trimester, there was like 56% of the cohort were only using by third trimester. So I think there's a lot there in terms of providing reassurance. There are some researchers in my scoping review study who actually looked at the dose of the medication, and they confirmed that it's actually subtherapeutic. People are giving below the recommending dose to actually control for mental health severity. That's not helpful. Those guidelines that we have in Canada now are really helpful to say use the lowest effective dose. Effective dose means we need to ask mom like how her mood is doing. Is the medication managing her mood? And is that holding as the pregnancy progresses? We know that time after is a really high risk time for women to have an escalation of mood and anxiety disorders, like symptoms displaying. So we need to be really careful. We need to have close follow-up. We need to be prioritizing maternal well-being related to that as well. So I think the guidelines are going to help us to, provide reassurance to prescribers, to healthcare providers, and hopefully we can have more conversations with families. And you may or may not be aware, in the Ottawa area, we have ASMASI. This is an initiative with Dr. Jasmine Gandhi from the Ottawa Hospital. She's a perinatal psychiatrist. That team is providing phone advice to prescribers. So if you're a family doctor, a nurse practitioner, anybody who prescribes medication and you're just really not comfortable with this pregnant or breastfeeding person, you can call ASMASI to get prescribing advice or even medical management. The other part of ASMASI's service is a consultation for resources and referrals, because sometimes if it's like low to moderate mental health, maybe it's like a community-based resource would be really helpful, like peer support or other types of intervention. So there's a lot of work we still have to do here in terms of really like having conversations, matching people to an appropriate treatment, and make sure if they need medication that it's appropriately prescribed and managing their symptomatology, because otherwise it's not helpful. You have
Yeah.
exposure without a benefit.
Yeah, great. Thanks, Christina. And we'll go to Tammy for the last question. I did want to ask if you have time at the end. I think this is great stuff for the precision child and youth mental health work, and postal code and genetic code, and so many areas of potential precision medicine approaches. So just thought I'd throw that out there, but one time for Tammy's question as well.
Yeah, absolutely, Pranish. I think it's right for that. And congratulations, Christina. I learn every time I hear from you, and I think like any good research, it spurs many other questions, and actually appreciate that, your initial hypotheses, some of them were disproven, and, that's as important as some of the other pieces. So I just am reflecting on the knowledge translation piece of this, and, we only have a minute or two, but if you have any thoughts on the knowledge translation, thinking that, in early pregnancy, it's typically would be the primary care providers that, have placed, new mothers or expectant mothers on SSRIs earlier in their lifetime, and then would be the ones that are sort of have that initial conversation now that they're pregnant or receive that notice of a positive pregnancy test. And so how do you reach them, and what are your thoughts on knowledge translation?
Yeah, we're trying to tackle this with the Champlain Maternal Newborn Regional Program. We have a perinatal mental health community of practice. So these are the very, very conversations that we're having. And in fact, we created a whole mental health support framework to really reflect there is a range of services and supports that could be available. Again, it's having a conversation and looking at like values and beliefs and priorities and preferences. So I think we have our 2 national guidelines now. They are consistent. Those authors work together. Those medication recommendations are the same. So that is amazing. That was intentional. That is very reassuring. So there's a lot of training support right now. Mental health has fallen within primary care historically here in Canada. That is not how it is in the US. Obstetricians see mental health screening as part of their role in the US. So Jasmine Gandhi and her team are doing a lot of outreach education to providers. We did a whole webinar series. I can send a link just about information, medical management, other types of treatment intervention. So I think we're early days here, like really getting back to let's have conversations with pregnant individuals in a respectful and safe way. And then let's start to have a conversation about what might be appropriate and acceptable in terms of addressing those concerns. I think we need to emphasize this message that mental well-being is important. I was just in Montreal last week, and there was a presentation on fathers. 10% of fathers have a mental health concern, and there's associations with negative adverse outcomes for the growing child. So we're moving to a point where we're needing to do family intervention. So I think that's where it's starting from. The guidelines are going to help provide reassurance. Here's the evidence base that we have. And to Pranish's point about precision health, the work that I've done with Dr. Ado Boafo, really just looking at the fact that there are genetic differences between individuals, and maybe, you know, a certain category of medication might not work for you based on, you know, how you metabolize that medication. So we've done a little bit of work looking at adolescents. I'm excited here at CHEO if we can stabilize the mental well-being of our adolescents in 10 to 15 years from now, when they become parents, you know, pregnant, then they could just be reassured to stay on the medication that they're on throughout the pregnancy, because their well-being matters, and that's going to make a difference for the pregnancy outcome. So I kind of see this whole system approach that integrates all kinds of aspects. Yeah, so it is an exciting time right now, and there's a lot happening with mental health. So thank you for everyone's questions, and I'm happy to follow up with anybody after to share more information and more resources if that's required.
Yeah, thanks for presenting, Christina, and congratulations again on your PhD. And hopefully this was much more fun than your thesis defense, but you did great. So thank you again for sharing.
Thank you, everybody, for joining this morning.
Okay. Bye, everyone.